Hello, everyone. We hope you're enjoying the Institute so far. My name is Larry Chang. I'm Best Center Director, and I'm very pleased to introduce our next speaker. The title of this session is Indoor Air Quality Management After COVID-19. And Dr. William Bahnfleth spoke last year about ASHRAE's recommendations regarding HVAC operations to mitigate the transmission of the COVID virus. He's going to give us an update this year, as well as some thoughts about how we need to improve on indoor air quality going forward. Dr. Bahnfleth is a professor of architectural engineering at the Pennsylvania State University, and his research interests cover stratified thermal energy storage, protecting building occupants from indoor bioaerosol releases, and then also the application of UV radiation to neutralize pathogens such as, well, you guessed it, COVID-19. He is a past president of ASHRAE, National ASHRAE, the recipient of numerous awards and accolades. And at any rate, we are really thrilled to have him here. Please join me in welcoming Dr. William Bahnfleth.
Hey, thank you for the intro, Larry, and I'm glad to be back in one sense, but I kind of hoped that no one would be interested in what I had to say on this subject a year after my last appearance here. There still is a lot to say. Let me get my slides up here. Hopefully everyone can see them now. I call this talk Indoor Air Quality Management After COVID-19. I've actually been giving this general topic for several months now, thinking that it was actually the time to do it. But as you know, that the pandemic is not really over yet, as these graphics show. These are just the world summaries for COVID, and the Omicron variant is driving infection levels to much higher daily totals than they've ever been before. The good news is that so far, at least, fatalities are holding steady, but there's no way of knowing whether we're really out of the woods yet and when things will get more or less back to normal. I have a few slides here at the beginning that touch on some of the other consequences of the pandemic. A lot of this was generated during the first year of COVID. It seems to have tapered off. It's harder to find updates to some of this data, but it still gives a picture of the kind of impact. This slide shows some estimates of potential loss during the pandemic that were done by some Harvard economists last year. And you can see there that when we had lost GDP together with the impacts of health effects, death, impairment, mental health, that we're talking about 90% of annual GDP as an economic impact. And that's probably underestimated now with the pandemic going on a lot longer than some thought it might have. The estimate, to put it in other terms, was 4 times the effect of the Great Depression, or twice the effect of all of the wars the US has been involved in since 9/11. Of course, there was a very dramatic impact on unemployment rates early on. So big losses there, and we haven't really recovered fully yet in terms of employment. There are many reasons for that. Maybe jobs aren't available, but actually we hear that jobs are available, and it's hard to get some people to go back to work. And the Great Resignation is maybe indicative of some of the psychological impact of the pandemic. getting closer to home and what we do, one, I think, very important statistic is the impact on how business is done. Again, this is a somewhat dated slide, but it shows that there was a fairly significant period of permanent office closures for some businesses. And part of the reason for that was maybe the space wasn't needed at the moment, but there are also employees who have had a taste of working from home or working remotely in other ways and don't really want to come back, which is, I think, further amplified by this slide that shows what the experience was in terms of how often people worked remotely before the pandemic as compared to during it. So if we look at before COVID-19, 47% didn't work from home at all. And after we got into it, there were nearly 50% that were working remotely 5 days a week. And so this has had quite an impact on the way that people view their desired lifestyle. I'm an academic and have been mostly working from home since March of 2020. Even though I've been going in to teach my classes, we're still by no means back to normal, and we're starting to see people's other desires for their lifestyle having an influence on how they work, and employers are to some extent responding to it. But I think at this point what we'd have to say is we're not really sure how this is all going to shake out, but it's likely that there will be less traditional 5 days in the office kind of work for many people in the future who were used to that. So lots of unsettling developments. It's always difficult to be in a time of uncertainty, but as Churchill said, we shouldn't waste a good crisis. I think we recognize the bad for what it is, but try to find some lessons we can learn from it and maybe some motivation to do things that we haven't done in the past. And I think improving indoor air quality generally is one of these. And that's my main message today, is let's not just think about ending the COVID-19 pandemic. Let's think more broadly about air quality and about other airborne diseases that we have come to tolerate, we've become familiar, and we put up with them. So we're going to talk generally about IAQ here, not entirely about COVID, and we'll go all the way back to definitions here because it's important to understand where we are in our understanding of indoor air quality. The EPA defines indoor air quality as air quality in and around buildings and structures related to comfort and health of building occupants. That is clear enough, but not very actionable. What exactly does quality mean? It's related, I think, to the levels of air contaminants that we find indoors and to the consequences of those exposures. What's a contaminant? Well, pure air is, we would define it if we opened a handbook, would be mostly nitrogen and oxygen, 78%, 21%, and traces of other things. Argon, after nitrogen and oxygen, is the next most common constituent of air, a little under 1%. And after that, that 0.04% of carbon dioxide, which has proved so troublesome to us in recent times because its effect on the climate. So quality, we need to understand contaminants and the levels of exposure and consequences. And then we have to define what acceptable means. Words that we think we understand. Acceptable IAQ turns out to be partly subjective and partly objective in terms of the criteria that we apply. And one person's definition of acceptable may be different than another's because of our beliefs about costs and benefits. So the the definition of acceptable IAQ today that is driving most building design and operation is like the one we find in ASHRAE standard 62.1. Air in which there are no known contaminants at harmful concentrations is determined by cognizant authorities, and with which a substantial majority of those exposed do not express dissatisfaction. So I call this the safe and satisfactory definition of acceptable IAQ. That there's nothing in the air that's going to maybe cause disease that's potentially fatal over the length of our lifetime, or an acute risk of death or disability. But mainly, most people think the air quality is okay, and that largely comes down to odors. But we've been happy with that for a long time, really since the 1970s, when ASHRAE Standard 62 was first published. One of these results of the pandemic that I think is a good thing is that it has led us to go beyond thinking about whether buildings protect us from airborne infectious diseases to asking questions about whether other aspects of indoor air quality ought to be looked at. And that's really what I would like to promote here, is that we would really benefit coming out of the pandemic if we dealt not only with the risk of another 100-year event like COVID or the 1918 influenza pandemic, but about what our indoor air is doing to us every day. So that brings us back to this question of what is a contaminant, and here's the composition of air that I was talking about before. There's really only two things in air that are there in very high percentages, and most other things to some extent are viewed as contaminants. But as Paracelsus said a long time ago, back in the 16th century, everything's poison, and nothing isn't a poison. It's the dose that makes something a poison. So what's important is not eliminating all of the things that might be in the air that are harmful, potentially harmful, because all of them are. If I put too much carbon dioxide into the air, or remove enough oxygen, I would suffocate. So everything is potentially harmful. We need to accept that and try to define what levels we can tolerate based on their consequences and the cost of dealing with them. And there are many air contaminants that have many sources and also many effects. So this could be an entire lecture in itself. So just in brief summary, we have many gases. Some are toxic, some have other effects, some are carcinogenic. Aerosols of many descriptions, from simple dust to secondary aerosols that are formed due to indoor chemistry, environmental tobacco smoke if smoking's going on, and then the contaminant of the year, the bioaerosol. Allergens, of course, highly important in terms of their effects, but pathogens are what we're thinking about now. Where do they come from? It's easier to talk about where they don't come from. Some contaminants come from outdoors, particulate matter, emissions from power production, from automobiles and others, wildfires, you name it. Some come from the building materials themselves and from finishes that we put indoors and in buildings. Activities are a big source of contaminants, cooking, burning candles, wood fires, all sorts of things that we like to do indoors that produce various emissions, and the occupants themselves. The bioeffluent that we produce is contaminant. Effects include some that impact simple comfort, which is what's dealt with by our standards today, perceived air quality. There's also sick building syndrome, which to some extent is an extreme example of discomfort, symptoms that are caused by exposure to something. Maybe we don't even know what it is. that are associated with occupancy in a building and go away when we leave it. All sorts of actual diseases, respiratory infections, systemic infections that go beyond the respiratory system, and cancers, acute toxicity, and well, that would be an example of something like carbon monoxide poisoning, for example. And the a really emerging area of performance, effects on productivity, cognitive function, learning ability, and even sleep quality. So some of these things you can see we're dealing with in that definition of acceptable, and some of them we aren't. So where are we today with minimum ventilation based on this definition of acceptability? We add up components of outdoor air that are based on the floor area of a space, and also on the number of occupants, and that gets us to numbers like 10 CFM per person for a classroom that has 35 people per 1,000 square feet. Excuse me, 10 CFM per person plus 0.12 CFM per square foot gets us to 13 CFM per person. That's getting into the range of what Fanger and others have found was the level of ventilation that will control odors to meet that 20% not dissatisfied criterion. So if you look at the figure over here on the right, at about 7.5 liters per second per person, we can expect about 20% dissatisfied. 2.12 liters or CFM per liter per second, which would be about 15. So we're close to that for a classroom. But if we looked at a multi-purpose assembly space, we'd only have 5.5 CFM per person. Or if we had an office space designed to 62.1, 17. So it's kind of all over the map, but basically flirting with what's acceptable for unadapted exposure. The reason some of the ventilation rates in 62.1 seem so low is that many of them are based on adapted response to odors, which lowers the amount of ventilation required by about 50%. That's good for energy. It's not really good for infection control. These are much lower levels than are used for infection control. WHO conservatively recommends at least 10 liters per second per person for non-healthcare facilities, which is about 21 CFM per person, and ASHRAE standard 170, which is a more complex set of recommendations, is at or even considerably above that level. There really has not been a march of progress in ventilation rates. Historically, they've fluctuated all over the map. So today we're still here about where we were in the 1990s with maybe at best about 15 CFM per person as an average. If you back up behind that, we had as minimums, assuming no smoking, only 5 CFM per person for a while, which was really when energy was driving the ventilation bus, which turned out to not be a good idea based on the emergence of sick building syndrome. These higher rates are when 62.1 still, or in 62 still included an allowance for smoking. So one of the ironic things about ventilation rates is that if we'd never taken smoking out of the standards, we'd have buildings that had outdoor air flows that were a lot more consistent with where we think we need to be for infection control. But before that, we had a level that was based on odor control at 10 CFM per person. And if you went back a century to around the time of the 1918 pandemic, for a relatively brief while, the recommended minimums, and some of them enacted in state codes, were 30 CFM per person, which is actually better than the WHO requirement and pretty close to the 6 air changes per hour of clean air that some have been recommending during COVID. So that's the situation for ventilation rates. Filtration, a little more straightforward. Historically, filtration was put into HVAC systems to control fouling of equipment and of surfaces, although you find some vague references in the early versions of Standard 62 to if particulate control is required. They don't say why, and they don't specify any kind of minimum efficiency. But eventually, we got a requirement in '62 to have a minimum of MERV 6 for systems that had wetted surfaces, and it stayed there for a long time and eventually got bumped up to 8. But those were essentially putting specific requirements on the old view that we needed to control mainly the larger particles that might cause fouling. There are 3 ranges where we rate filters under ASHRAE standard 52.2, and a MERV 6 or a MERV 8 filter doesn't do very well in the first range from 0.3 to 1 microns, or in the second from 1 to 3 microns, and that's where most of the respiratory aerosols are that we're concerned about. So we don't have a very good standard in terms of protecting people's health during a pandemic, and as I'll point out later, also from other perspectives as well. This figure shows that for a MERV 8 filter, which has no requirement for particles smaller than 1 micron, and only 20% for 1 to 3 microns, most of the particles that it's capable of removing efficiently are in a range that wouldn't make it past your nose and mouth, and tends to let through the particles that wind up in the alveolar region of the lungs and can cause lots of health effects, including infection, but also other impacts as well. So that's where we are. We've known that this was the case for a long time, at least if we were listening to the people who were looking at it. In the last year, this book by Joe Allen and John McCumber has had a lot of impact, making the case for healthy buildings. And I think it's really good to update that case, and I recommend it. But I also want to point out that Bill Fisk at LBNL, amongst others, was saying the same things and putting numbers to this almost 20 years ago, how IAQ affects health and productivity. So we had research that was documenting this 20 years ago that we could have acted on, but didn't. So we're ignoring in our current standards the kinds of losses that have been documented from many studies about increased sick building syndrome symptoms, as shown on the left in this figure, as we increase ventilation rate from current minimum levels, 7.5 to 10 liters per second per person. We get quite a significant reduction in the mean of a lot of studies of sick building syndrome symptom incidence. And again, some of Sepinen and Fisk's work analyzing multiple studies, similar increases in ventilation rate would be expected to improve task performance by 2 to 4%. I don't want the focus here to necessarily be entirely on ventilation, although that's where a lot of the studies have gone, but just think of this as removing exposures to the contaminants we normally find indoors. And this starts to be relevant to other ways of controlling indoor air quality. Filter efficiencies likewise have consequences that we've known about. This is I think, one of the clearer analytical studies by Montgomery et al. That looked at the morbidity and mortality impacts of using different MERV filter levels in different locations. So we have in this figure in the middle locations that vary from Vancouver on the clean side to Delhi, India on the dirty side, and the predicted performance of different MERV rated filters in terms of reducing exposures to PM 2.5 and their health effects. And so here's our current MERV 8 level with maybe $150 per person per year health savings for the locations where the greatest effects would be realized. And if we took that to MERV 13 in those locations, we get about a factor of 4 improvement in the healthcare costs and personal costs avoided, mostly by reducing mortality. And why is there a knee in this curve? It's because when you get to about MERV 11 or so, that the efficiency for PM 2.5 is high enough that you start to take out the particles that really have the health effects. We go from nothing to 50% minimum in range 1, 0.3 to 1, and 20 to 85% in range 2. So there's a lot of motivation for doing something. ASHRAE is in the process of trying to do something about it through a strategic plan. Just before the pandemic happened, we published a strategic plan that was emphasizing both indoor environmental quality and resilience, which fits in quite well with some of our current concerns, epidemic or pandemic disease, and also things like wildfires that are an example of periodic, very acute outdoor air quality emergencies. But not quite in time, and there's still a lot of work to do there. We've been talking for a long time too about whether we're prepared or not for the next influenza pandemic. CDC was having meetings about that to commemorate the centennial of the 1918 pandemic, and they noted then the worrisome increasing emergence of novel strains of influenza. And that plus their assessment of readiness should have led us to be concerned. And even though it turned out that it was an entirely different pathogen, coronavirus, that was the culprit now. So 100 years later, we're really repeating a lot of the experience that we had back in my grandparents' and great-grandparents' days. Lots of closures of schools and churches and businesses, and the same arguments over masking, actually, and the formation of factions promoting wildly different viewpoints on what was necessary and appropriate. Of course, there wasn't any vaccination for influenza in those days, but I'm sure that if there had been, we could add that to the list of things that the people were arguing about. Good to keep in mind that partly because there wasn't vaccination and because healthcare has progressed, that if we had a pandemic of the scale of the 1918 pandemic now, it would be worse by several factors, not by orders of magnitude, but by a lot. There were 50 to 100 million deaths in 1918 when the world population was less than 2 billion, and today there are 8 billion people in the world. I think probably the biggest factor working against us now is how rapidly diseases can be transmitted because of the population density and the amount of travel. So that's the really the background, I think, on the consequences of the pandemic, and also some of the things that we ought to be thinking about with respect to how indoor air quality could be improved. Say a few things specifically about COVID, some of the lessons that I personally think we've taken from all of this experience over the last 18 plus months. One of them is that airborne transmission of respiratory infections really does happen and can be important. That again is another long discussion to go through all the history of it, but it was really kind of surprising that it took so long to come to the conclusion that the data we were seeing actually supported airborne transmission pretty clearly, and that we should do something about it. That goes along with the next point, which is that there are some old orthodoxies of infectious disease transmission that maybe need to go away after the pandemic is over. And I say that, as a mechanical engineer, but I've talked to a lot of epidemiologists and microbiologists and researchers in this area, and I think that the old droplet model of transmission has taken a serious hit in the last couple of years, and that it will come out with something different. The third point also flows out of the first two, which is the precautionary principle, which I'll state in a moment or two, is really important. It has to do with when we act on evidence. Do we wait until things are 100% or nearly 100% certain, or do we take a different point of view based on possible consequences? We've also learned, at least for most of the strains that we've seen, that most infection occurs indoors. A pathogen has to be really, really transmissible to be able to get much transmission outdoors unless people are in high concentration in an outdoor environment. And of course, simply being outside of a building, maybe under a tent or something, doesn't necessarily always mean that you're outdoors. We've also learned that HVAC systems can be important in risk mitigation, and likewise, they can be important in some ways in transmission of disease as well. So it's important to do something about them. But strangely, there's a gap in the guidance from many authorities that goes from vaccination to testing to contact tracing, and leaves out ventilation and air cleaning and other things that we can do to reduce indoor exposure. And the other thing that we've learned clearly is that existing buildings don't provide the level of protection against airborne transmission that perhaps we'd like them to. It took a long time to get to a statement like the one here from CDC on COVID-19 transmission. This dates to May 2021. So we were already 14 months into the pandemic when CDC, and at about the same time the World Health Organization, finally started noting that inhalation of fine infectious aerosols could be a significant risk factor. Prior to that, droplet transmission, which is called deposition in this more recent statement, was considered to be the predominant mode, and often fomite transmission, touching of contaminated surfaces, the third item listed here, was considered to be more important than inhalation. So this change of perspective is quite significant, and finally helps to put us on a path to doing the right things. But the unfortunate problem is that when we first had data that was pretty persuasive about the possibility of indoor airborne transmission, there'd only been 100,000 deaths. This is back in globally, back in March of 2020. We finally got some, well, in special circumstances, unusual cases, there might be indoor transmission, million deaths at that point. By the time the statement that was on the previous slide came out, there'd been 3 million deaths globally, and excess mortality data suggests that the actual numbers might be 2 to 3 times as high as that. So now that there have been 5 million deaths, 5.5 million reported as of yesterday, we might really be looking at globally 15 million, which is starting to get into the same range as the 1918 pandemic. So what is the precautionary principle? The precautionary principle is that one should take reasonable measures to avoid threats that are serious and plausible. This is something that I started hearing from the clued-in infectious disease prevention people over a year ago. You don't wait until you have perfect proof to do something if the consequences of not doing anything and being wrong are severe. And so this is the thing that I think was the missed opportunity, was to say, okay, we're going to be conservative and start taking measures to control airborne transmission indoors a long time ago. There's absolutely no way to estimate what the impact would have been, but it would have been positive. And I think I feel very good that at least ASHRAE and REVA and some other HVAC organizations came out with statements that were essentially invoking the precautionary principle very early in the pandemic and started putting guidance out that could be used by those who were persuaded by the argument. But the long time it took for public health messaging to catch up has certainly slowed us down. One of the other things that we've learned that's important is that risk is multidimensional. COVID's not all airborne. Droplet transmission can happen. There may even be fomite transmission, although there aren't good studies documenting it. But we now all know, I hope, that there's a hierarchy of measures we can take that when we do as many of them as possible, layer them together, can help to control risk. So that means following public health guidance and trying to eliminate sources, keep sick people out of buildings. Substitution, maybe not applicable, but I've heard people say substitution could be doing something outdoors instead of indoors. Engineering controls are the next most important level in terms of their effectiveness, and yet one that has not been, I think, promoted clearly or strongly enough in guidance that comes from really authoritative government sources. Rules and personal protective equipment can help, but the problem with them is adherence. And hark back to my comment about arguments about masking and then also about vaccination. So some of the factors that are important to us in looking at HVAC systems related to infection transmission or poor ventilation. Very early on, we had this study of a restaurant in Guangzhou, China. I talked about it a lot a year and a half ago. I don't think we even need to talk about it anymore. I think it's now accepted that this was a case where a combination of very low ventilation rate, unventilated space, essentially just air leakage, and movement of air that determined who was exposed led to a super spreading event. We've also seen that poor air distribution can be a factor in transmission. So this is another restaurant case, this one in South Korea, where one infected person infected several others in a very short time span at a significant distance because there were strong air currents being created by the interaction of the flow from a couple of VRF cassettes. So these two people are sitting 6 to 7 meters away from the infected person, and cell phone records indicate that they were in the restaurant with that person, in one case 5 minutes, in the other case 20 minutes. But this air current that was measured from this table to this table was over 1 meter per second. So basically 10 times what we would consider a typical still air velocity in a room, 20 or 40 feet per minute. So I think this is an important finding because my observation is we don't pay a lot of attention to the details of air distribution in most spaces, and things like this happen all the time. We also see lots of returns sitting next to supply outlets and many other things that shouldn't happen. So it's an area we need to work on. And we've also found that uncontrolled airflows can cause significant outbreaks. And on the left here, apartments in an apartment complex in South Korea that were connected by open natural ventilation shafts so that air could flow into or out of any unit connected to those shafts. And there was a big cluster of infections along it. And as in the case of the original SARS outbreak, we've seen infections through plumbing when traps were dry. This points out that air tightness and airflow control in buildings is important. So it would take me about another half hour to go through ASHRAE's recommendations that really build on these observations, but I'll just point them out to you. We've developed hundreds of pages of guidance that you can find at the website shown at that URL, but we did boil them down to a single page. And so if you want to get the the view of what's there quickly, I suggest you read that. This was determined from a process of extracting the main things we wanted to say from all of this guidance that was kind of put out quickly in the heat of the first rush of activity, and taking into account some things that we had learned in the process. So what does it cover? Public health guidance, ventilation, filtration, and air cleaning, air distribution, system operations, and commissioning. Public health guidance, because it's really important to put together as many layers of protection as we can, as shown, for one, in this figure on the right. This shows some data from last summer about hospitalization of COVID patients, unvaccinated versus vaccinated, and the impact of COVID relative to influenza and other illnesses and causes of death. And it shows pretty clearly that the unvaccinated are very much at risk, and that if everyone was vaccinated and we had these smaller numbers, that we would be keeping things down to a more manageable level. As far as masks are concerned, the reason we really want to emphasize those is because they help with control of exposure in a number of ways. So the emission of respiratory jets can project infectious material in concentrated way far beyond the 2-meter distancing radius that we tried to enforce early on in the pandemic, as shown by this guy wearing a face covering. But also, a mask worn by someone who's infected reduces the amount of material they emit, and a mask worn by someone who's not infected reduces the amount of infectious material they inhale. And that's shown in this figure that comes from research by UC Davis. So efficiency of mask for one person versus efficiency of mask for the other. And so if we have 2 people wearing 40% efficient masks, maybe only like a surgical mask, we go over 40-40, and that reduces exposure by 60%. And if you're wearing a good N95 or KN95 mask and getting up close to 90%, it has a very significant impact on airborne exposure, perhaps more than anything else that we could do. So those are some of the things that we've learned about reducing the risk of COVID indoors, and we can talk in the Q&A about some of the specific measures that I didn't have time to go through here. But I want to wrap up here with what the future should look like. And you may have seen this article that was in Science promoting a new paradigm for respiratory infection control indoors. And basically what it's saying is we've been letting indoor respiratory infections happen for a long time, and we now know that there can be severe consequences to doing that. Why don't we view that as being something that's preventable in the same way that exposure to contaminated water might be, and make some changes in our standards for buildings. This would help us not only when we have another pandemic, which might be a long time, but we've seen during the last year of COVID, when a lot of restrictions were in place, that we had a very mild flu season. So last year was what, the 2021, the brown line here, below normal, no big seasonal peak. Now that we're going back to more normal activities, we're seeing things coming up again, although I want to note that it's possible it's just strains varying from year to year can also contribute to this, but we may be able to do something about seasonal burden of disease, which is pretty significant. Here are the typical ranges for the US: illnesses, hospitalizations, deaths from influenza. So that's the argument for dealing with infection control, but I think we should go all the way back to the beginning and say, what's our definition of acceptable indoor air quality? And modify that to include health and wellness, which would bring in infection control. So Harvard has defined these 9 foundations of a healthy building, many of which have to do with thermal and air quality control. That's something we're all concerned about. And those contribute to wellness in many ways. Physical wellness, our health, absence of disease, but also occupational. We can go to work, we can make money, we're more productive. Intellectual, cognitive function better. So there are many benefits here, which to some extent have been quantified. And the other part of the definition would be resilience. We don't design buildings now to deal very gracefully with emergencies that only come around once in a while, like an epidemic disease or a wildfire. Until we change our approach to design and operation, these will continue to be big problems. I don't think that it's a slam dunk here. I don't believe everyone's convinced, or even a majority of people, that we can do these sorts of things. And here are some of the barriers to doing it. Not everybody believes the science. There's my science and your science. So that's a long-running discussion about whose data is correct or whether it's being interpreted correctly or cherry-picked. Another is that this economic justification for better IAQ is not widely enough known, even though we've been trying to spread that word for decades, as I showed. Split incentives is another big problem. Who pays, who benefits? That becomes a societal issue, and working out how to share the cost of doing things that will help society generally. That probably means some policy and regulation changes, and we have really a fairly strong regulatory aversion in the US. I don't think I need to tell anyone. And then really more positively, I think there is currently not a workforce that exists that's really highly trained to deliver good indoor air quality. So this is an opportunity as much as a barrier. I think this is something we could work on, and it would create jobs, and it would also make our indoor environments better. There is some question of liability attaching to trying to make buildings healthier, but honestly, if we look at that carefully, we're already making claims about health in our existing standards like 62. So I think that's something that we can get by. But one of the big problems is also this conflict that always pits energy against indoor air quality, that better air quality means more energy. And today, with the obvious development of extreme weather events related to climate change, that's a big problem. And then there are also some gaps in science and technology that need to be dealt with. I think we know how to start moving forward to have sustainability in the sense of climate action, number 13 on the UN list, and also have good health and well-being, which I have to remind a lot of people is also part of sustainability. So this is the challenge. Can we stop creating two camps, the decarbonization folks and the indoor environment folks, and can we all recognize we're on one team trying to solve an integrated problem? I think there are only two great crises facing us right now, indoor environment and outdoor environment. And I think we're going to have to collaborate to solve the problems. So some things we can do, maintain systems properly. You saw commissioning was in the list of ASHRAE guidance. We can save a lot of energy and make buildings perform better by having regular maintenance of them, which often doesn't happen. We discovered that when we started looking at people's portfolios and whether the ventilation was actually being provided or not. Designing for resilience, I've already covered that. There are a lot of efficient ways to increase ventilation if that's going to be our solution, everything from energy recovery to hybrid and natural ventilation. I think alternatives to ventilation are going to be really critical. Source reduction, of course, is something that we've done for a long time. Get smoking out of buildings, get asbestos out of buildings, reduce VOC emissions of finishes. But air cleaning I think, as an alternative to high energy ventilation is going to be important. And using these things effectively are also going to be enhanced by combining smart building concepts with our goals of healthy buildings and resilience. So better use of sensors and better use of more sophisticated demand controlled ventilation and air cleaning, occupant interactive controls to improve indoor environment energy efficiently, and optimizing the performance of these systems with automatic controls. Research gaps, just very briefly, I think risk assessment is one of them. One of the problems with persuading people that what I'm telling you is true is the uncertainty associated with the impacts of different exposures, whether they're chemical, particulate, or microbial. We're pretty sure that they're significant, but they have fairly wide confidence limits. Performance of air cleaning technologies in realistic applications is a big issue that has been much discussed during the pandemic, but it affects all sorts of controls: chemical, particle, microbial efficacy, and also safety. Do air cleaners produce byproducts? And some of this will feed into standards that we need. We don't have much regulation or certification of air cleaners right now. We need methods of test and certification programs that will help us to understand what actually is going to be fit for purpose, and improving our understanding of exposure limits so we can define indoor air quality more quantitatively than we do today. So finally, the end, we've been stuck in this paradigm of mediocre IAQ for a long time. Odors and just basic safety. The pandemic has hopefully shaken us free of that way of looking at things by showing us really severe consequences for holding that point of view. I think part of the good news is that we have a lot of tools in hand right now that will help us do things better. We just have to deploy them differently. It's not that ventilation and filtration, say ultraviolet air disinfection, aren't enough. We just aren't using them enough yet. Big potential benefits, if we do it, will be realized, but many barriers to that, as I've noted. And the final point is, if you take one thing away today with respect to events like what we've been living through, remember the precautionary principle and live by it. Take reasonable measures to avoid threats that are serious and plausible. Right, so I'll stop there and hope there's time for some questions and comments. Thank you very much.
Thank you, Bill, for that outstanding presentation. We definitely have questions here. The first one regards the orthodoxies you mentioned earlier that really need to be reevaluated. And I noted that you mentioned the droplet theory. Could you kind of expand on that and give us examples of the others that you mentioned?
Yeah, I think that is the main one. It comes from I think a misinterpretation of data a long time ago, and a lack of understanding in one discipline of what another one can tell them, namely what aerosol scientists know about the behavior of small particles. So it's been a long-running argument, actually more than 100 years, of how disease transmission occurs. And someone did notice a long time ago that it seems like infection is more likely when people are closer together. So this led to the conclusion that if that was what was happening, then infectious material must be in large droplets that are emitted by coughing, sneezing, or respiratory activities, because they couldn't travel very far. And it's true that that there is infectious material in those large droplets, but the really big problem was that someone misidentified the range that should be associated with large as being larger than 5 microns. And actually 5-micron particles can move a long way in an indoor airstream. Really, some of the aerosol science research that's been done in the last couple of years has pretty clearly identified 100 microns as a better break point. So that was one problem, was that we had a whole infectious disease prevention community that had been told that it was the large droplets that were the problem, and that the large droplets were actually pretty small. But the other issue was that we were forgetting, or someone was forgetting, that when large droplets are being produced, a lot of small ones are also being produced. And they're in higher concentration near the infected person. I won't answer that. Just as the large droplets are. So your risk of inhalational exposure is much higher when you're close to someone, just as droplet exposure is. So when you put that together with all of the evidence for infection at fairly significant distances that are way outside this 2-meter radius, which we've been seeing from the beginning of the pandemic, it makes you think that this large droplet is the main risk factor. Concept is just wrong. And the problem with it is that it sent us down the path of saying, well, you only need to have respiratory protection if you're very close to someone who's infected, when really it would have been better if we'd been wearing masks anytime we were indoors from the beginning of the pandemic, and if we had been taking measures to lower the airborne concentration. Omicron is really pointing that out really effectively, because it may be, I've heard someone say, the most infectious virus found to date, up there with measles. There's a case study that was published recently where it seems that people were infected across the hall from someone who was in a quarantine hotel, even though they never saw each other, just from airflow from one room to the other. So that's the gist of it. There's some very good articles out, both in the popular press about, say, Lindsay Marr's work, and also an article that we've published on the history of it. I could point people at lots of articles about myths about airborne transmission that would explain this more fully.
All right. The next question relates to economizers, and certainly here in California, being challenged with wildfire smoke, that certainly precludes the use of high concentrations of outdoor air. The question is, can we modify these systems, or do they need to be completely removed and replaced?
Well, this goes back to the idea of resilient operating mode. So instead of just having an economizer that's enabled all the time, when you design the system, or if you look at an existing system, think about what would be the best thing I could do if there was a wildfire, and then obviously opening up the outdoor air 100% just because it's cool or low enthalpy outside isn't a good idea. So then the question is, what am I going to do when that happens? I'm probably going to go to minimum outdoor air, maybe even if it's short term to no outdoor air, but then I've got to have, if I have any outdoor air at all, I have to have better filtration of outdoor air than I have now. So maybe I don't put MERV 14 or 15 filters in my outdoor air intake all the time, but maybe I have the ability to do that if there happens to be a wildfire. Our ability to deal with those sorts of issues is going to get better if we think through it ahead of time and do it for new systems, instead of trying to put band-aids on systems that weren't conceived that way. But obviously, during the pandemic, putting in high efficiency portable air cleaners indoors that don't bring in any outdoor air is a good idea. Singapore has dealt with this problem for naturally ventilated buildings. So what if you have no mechanical system at all? And interestingly, a long time before the box fan plus filter kinds of devices that we've seen become very popular these days, much discussed on social media. In Singapore, they were doing research on doing the same thing to treat outdoor air. So I got some colleagues over at National University of Singapore who published multiple papers on basically exactly the same thing, except what they're doing is putting the filter on the outdoor air that they're bringing in through a window. So there are solutions, but we should have a plan before the emergency happens. This is maybe the main point I'm trying to make. And I should also mention ASHRAE is developing a guideline on wildfire smoke mitigation. I'm not sure how soon it'll come out. I think it's guideline 44P because it's proposed currently, but there should be something on that available pretty soon.
Good to know. Yeah, I was not aware of this pending guideline.
Mm-hmm. You can find it at the ASHRAE website. Just Google 44P and you'll find such information as is available about it. Steve Emmerich from NIST is the chair of that committee.
All right, good to know. Here is a question that certainly speaks to your research interests. What are your thoughts about using UV technologies, again, in controlling and mitigating pathogens? And in particular, this person was asking about its application in lighting systems.
Yeah, well, of course, currently the primary source for UV is essentially a modified fluorescent lamp. It's a low pressure mercury vapor lamp that has a doped quartz tube instead of phosphoron glass. And so the germicidal UV that's produced inside of both lamps, one of them it's re-radiated as visible light, and the other it goes through and does its germicidal function. Very long history of study of that technology. It's can be quite effective when properly designed and implemented. It was used to reduce measles transmission in schools very effectively in tests done by Harvard School of Public Health in the 1930s. So it's been around for a long time. It's approved for tuberculosis control by CDC. So it's really a very well-known technology, but the best implementation of it, the upper room system where we put lights in the upper cavity of space, is pretty expensive. There are some emerging technologies like far UV, specifically krypton chloride excimer lamps that produce 222 nanometers that may be safe for human exposure and could be used to irradiate a whole space. There certainly is the possibility of combining that with lighting fixtures as well, or having LED lighting that has LEDs that produce different wavelengths that could be used both for occupied and unoccupied mode disinfection. So I think there's a lot of potential there, and anytime you can combine technologies to reduce costs, it's going to help overcome that barrier. I think that's the biggest problem right now, from my point of view, is that upper room UV is dollars per square foot for typical commercial fixtures, which is prohibitive for a lot of people.
Well, we are past our kind of stop time here. I'll just see if there's any last question. Oh, here we do have one. Does ASHRAE have any standards or guidelines regarding staffing levels for operations and maintenance to address building safety and health concerns?
I would have to say I don't know of any standards for staffing levels. ASHRAE would be more likely to be involved in what maintenance needs to be done, more so than what number of personnel are necessary to do it. But I'm going to say that's not really my main area. So there may be something there that I don't know about, but I'm not aware of it.
On that note, Bill, thank you so much for all of your efforts. Please keep us posted on future developments regarding your research and advocacy. And it sounds like someday we may be seeing some revisions to Standard 62. So
I would expect 62.1 and 2, or maybe a separate guideline, but I'd rather see those standards change and those changes get into the codes. So if anybody has burning questions that we didn't get to, you've got my email address there, and feel free to email me, and I'll try to get to them as soon as I can.
Terrific, yeah. And you see Bill's email address here on that slide. And just as a reminder to everyone, please be sure to go to the expo hall and check out the booths. There are tons of links and documents and plenty of resources, both on the educational as well as the technical and product side. So, make good use of those resources. All right. On that note, thanks again, everyone, and we'll see you at the next session.